on 3 views of the CT scan. So this is a coronal view, is cut from the front to the back of the head, and this is a sagittal view, which is cut, sideways, and this is an axial view, which is cut from the top to the bottom. And when you look at the cross section of the green line, they all fall inside of the right frontal sinus. So that this tells the surgeon exactly where he is, if there's any question. It's a very useful technique for patients who underwent multiple previous sinus surgeries. Like I said, they've had altered anatomy. So sometimes it's, especially when it's near crucial anatomical structures, this is a very valuable tool for the surgeon to navigate during the surgery. So just very quickly, in terms of the future directions to treat chronic sinusitis and chronic sinusitis among CF patients, there are several studies have suggested that long-term and low-dose macrolide antibiotic may have a beneficial role in treatment of chronic sinusitis, cystic fibrosis, and some other chronic pulmonary inflammatory disease. Supporting in vitro evidence of their anti-inflammatory activity. So not only antibacterial, but also anti-inflammatory activity. So in our center, sometimes we would put the patient on clarithromycin or Biaxin, a daily dose at 500 milligram for 3 months, and to test out the anti-inflammatory effect. You probably heard a lot about treatment targeting the biofilm. So what's biofilm? It took a while for myself to really understand the concept of biofilm. So biofilm basically is a complex aggregation of microorganisms marked by excretion of a protective and adhesive matrix. So Pseudomonas colonization among CF patients probably represents a biofilm state, whereby the bacteria exist in an organized community with attachment to the surfaces in a very thick mucus. The bacteria in biofilm exhibit increased antibiotic resistance and are less susceptible to host clearance mechanisms, and therefore it's harder to clear with conventional antibiotic treatment. So a great deal of research is underway to discover the medical means to disrupt the biofilm, such as detergent rinse or baby shampoo rinse. You probably heard about that. And also the use of xylitol, which is a naturally occurring sweetener. It's used in a lot of dental products because we believe the dental plaque is a form of biofilm. And lastly, of course, is the gene therapy. So gene therapy for CF involves the insertion of a DNA encoding a normal CFTR genes into the respiratory tract. As more and more is learned about the molecular structure and the function of this specific protein, as well as modifying genes, more avenues for effective therapy are open in the future. Yes?
So our typical treatment, and certainly we know our patients are colonized, for Pseudomonas is a 2 antibiotic choice treatment. Because so many of them have the mucoid Pseudomonas in addition to the Pseudomonas associated with the biofilm, we do use an agent to penetrate the biofilm and then an agent to actually get into the cell because it's so complicated. The reason why I'm referencing that is, do you ever do a 2 treatment instead of just 1 treatment with regards to your antibiotic selection?
Sometimes we do. Again, it's based on the culture, yeah. And sometimes one antibiotic, there will be multiple bacteria being cultured out, and one antibiotic doesn't cover all, and then we have to choose another one to cover. Or especially if there's 3+ and 4+, then we have to treat it. Okay. Yeah. Yes, sir.
So in the CF maxillary sinuses, when you take out these, you sometimes find these masses of bacteria. Can you tell when you're mechanically removing them, are they adherent to the mucosa? Do you actually strip away mucosa when you pull them out? Or are they separated, still in the mucus, so that there's a clean mucosa left behind when you take them out? The cilia is still there. Can you tell that?
I probably should have Dr. Wang answer the question since he's the surgeon. I believe we preserve the mucosa instead of stripping it.
That's right. So,
Yeah.
good evening, everybody. Sorry. So if we're in the office or in the OR and we're cleaning the sinus, you can still see that at least from the larger view, the mucous membrane is intact. But if you were to take a microscopic view of that, you would probably see a lot of injury of that surface tissue, because it's thought that when you lose the integrity of the structure of the surface, it makes it more susceptible to the bacteria setting up shop and invading. So it looks normal, but we know that it's not. And we know that the cilia are probably impaired because there's a long-term colonization of the surface. In addition, you have white blood cells that come to that area, and the white blood cells, they participate in creating inflammation by releasing a lot of toxic chemicals into that surface. So again, it sort of further impairs the integrity of that surface. So grossly speaking, the mucosa is intact, but microscopically speaking, it's pretty damaged. And so we do think that removing that bacteria on a regular basis, which is why we often have people come in for cleanings, or why we suggest that they use these irrigations on a regular basis, reduce the amount of colonization, to hopefully allow that tissue to recover. But in CF, it's an ongoing battle because the mucus just is inherently thick and difficult to clear.
I just ask a follow-up to either one of you. Given the white blood cell counts in there, do you use Amazon?
Yeah, there's been a clinical trial, but actually something I've been very interested in. But there's no, it's not something that I think is widely available. We don't use it currently. I thought about proposing a trial for E.M.T to do that, and I know that probably 5 or 6 years ago there was a limited, like a case report of the use of it. But I think in their marketing plan, it wasn't a big enough piece of the pie for them to pursue because of the expensive clinical trial. But it may be something we could pursue on a compassionate use basis and try it. I have been interested in seeing whether that would be useful.
As an adjunct thought, what about a mucolytic like this in order to break down some of that? Could you use
Yeah,
that?
I think you could use that. I mean, that's what some of these, the detergent rinses are also breaking that down as well. So basically, it's just a way to, it's really breaking the biofilm. Because I think it's very hard to separate what is thick mucus associated with cystic fibrosis and what is a biofilm. Because I think the thick mucus is basically the foundation for the layer of biofilm, because it's immediately colonized with the Pseudomonas. So I think it starts out as thick mucus, but then it becomes a biofilm quickly. So I think just a pure mucus thinner alone is probably not going to be enough. But we actually are involved in doing some research looking at the chloride CFTR, the channel, the chloride channel, and its effect in sinusitis in both CF and non-CF patients, and the inducibility of the chloride pump activity. And there are some agents that we're looking at that may enhance that level of the sinus. And so one way to thin the mucus would be to enhance chloride pump activity. So there may be an indirect way of thinning the mucus by actually enhancing CFTR. Or actually, it's a more direct way of enhancing the mucus consistency.
Regarding the 5 transports, there is one that's been able to be stabilized with the drug, but it's still not been doing it. Outside of that, there really doesn't seem like there has been great success in what we just mentioned. That was fabulous stuff. No one's talked to me about that.
So right now we're really looking at mechanical removal, and it is the primary goal.
This is a follow-up to that. So you have surgeries, every so often, but when you see a patient in the office, do you actually, because I've had a number of different E.M.Ts over the years, and some believe in clean, we go and clean the whole sinuses out. Each time you go to see him, you see him every couple months, and then others don't. So is there like...
I would ask you how you're doing.
Right.
And you kind of know, I mean, some, just as the different phenotypes, there's different people who have a different degree of colonization. Some people actually tolerate a lot of colonization quite a bit. You look in their nose and you say, oh, you must be miserable. And they're like, I feel great. Well, I'm not going to make that, and I know if I've seen that patient every few months, and that's how they always look. And we can do photo documentation in our office, so we have a video file of all of your exams. There's no reason to chase that because it's just going to build back up. But if it's somebody who normally has minimal colonization, and then you say you come in and you feel miserable, or you think you got a cold, and you look and you see just this thick pool of mucus, I can't let that go. I mean, I'm going to want to culture that anyways, but I'm going to want to remove it just to help accelerate the recovery from whatever the is.
So then you basically it's individual based on their
Definitely
symptoms.
is, yeah.
And with the baby shampoo, I've used baby shampoo a few times for rinses and stuff, and it seems to work, which, I mean, I feel like a bubble machine, but, what about the other one, this is called xylitol? Does that have the same effect?
It works differently, so xylitol is it's a sugar, so it tastes sweet, and it's a sugar molecule that's not absorbed by the body. So it's kind of like, if you look at some of the sugar-free candies for diabetics, it's made with sorbitol, and it says the caveat is may cause GI distress. That's because it's not absorbed by the body. And so xylitol is like sorbitol. So what happens is the molecule will draw water to it. Wherever the molecule is, osmosis, it will pull water in. So if you spray xylitol into your sinus, you taste the sweetness, but it doesn't get absorbed into the tissue. It'll draw the water to where the molecule is. So we like to use it because, most patients, especially the CF patients, have been on so many medications. This is something you can get at Whole Foods. You don't need a prescription. It costs $12, not $200. And I would say that maybe a third of patients find it helpful. That would be about the same as the baby shampoo. Not everybody finds that helpful, and some people find it irritating. So what we're trying to do is just provide lots of different options for patients, and everybody comes up with a different combination that works for them. So it's one of those where there's not really a downside to it, and you can use it as often as you want. You can actually buy it in bulk, and you can actually mix it into the saline also. And we've also done a clinical trial just using xylitol irrigation without the salt compared to just saline. And in a non-CF population, it seems to be beneficial, even without the salt. We occasionally recommend hypertonic saline irrigations for the CF patients as well, just as the hypertonic nebulized treatments. We will sometimes recommend that if it looks like they need help with mobilizing the circulation.
This is a side question. Do we ever get our sense of taste back if we lose it?
Well, your sense of taste is tied very closely to your sense of smell. And so probably, if you look at the nerve for your sense of smell, it's there and it wants to smell, but it's buried beneath so much swelling that the amount of swelling that the molecule that's coming in your perfume or whatever has to overcome, it can't reach the nerve. So the nerve conduction is intact, it's just not receiving anything because it's buried deep in that swollen tissue. So it's a very difficult thing to maintain long term if you don't have it at baseline. But that's why we try things like topical steroids, steroid irrigation, to try to reduce that swelling and try to optimize if there is a sense of swelling.
Because we have so many patients that malabsorb and are malnutrition even with the G-tube, the sense of smell and taste is so critical for them. What sinus is that involved predominantly with? Like when you referenced which one were you?
It's actually the nasal cavity itself. So it's not in the sinus in particular. It's at the top of the nasal passage. So if you think of the nasal cavity as like a triangle and then the sinuses are outside the triangle,
Okay.
the olfactory tissue is at the top of the triangle.
Okay.
So it's the very top and the back of the nose. And Jane can show you there, yeah. There and in the back. And so if you have sinus drainage, it'll cause the swelling of the nasal lining too, because the secretions are being pushed into that area, and that's enough to cause, because it's a very delicate sense, so you'll lose it pretty quickly.
Okay. Show.
Is it possible to over-irrigate and defeat some of the natural processes?
You mean over irrigate with the saline solution? I've never heard of. I've read some articles. patients ask about, how often am I supposed to irrigate, we always recommend 2 to 3 times a day, but you can rinse as many times as you want if you have the time and energy to do so. It's normal saline 0.9% sodium chloride is a physiologic fluid. Yeah, I mean, if you use a hypertonic solution, if you rinse multiple times, I would think theoretically it draws so much water out, it could dry you up. That might not be a good idea, but I've known plenty of patients using hypertonic rinse long term, and they seem to be okay. Yeah, especially a CF patient.
What percentage do they use them? 7% or 3%?
Of hypertonic, I don't know. What I was told is they just, instead of mixing 1 packet of the salt, that comes with the new E.M.T sinus rinse, they just put 2 packets in it.
In the
Yeah.
sinus rinse packet, is there also non-bicarbonate?
There is a bicarbonate, yeah. So the saline solution is
Sometimes
buffered.
It's not the same as the packet. I'm like, all right. So I looked at the packet one day and I saw the bicarb, so I'm like,
Yes, yeah.
I wasn't sure exactly what that impact had. But it's-
Yeah, there's always the salt and the bicarb. Yeah. Otherwise, it would be burning and uncomfortable. Yeah. I just want to quickly finish. I just have just a couple more slides. Okay, we can just go from here. Just quickly, some of the research projects, and there are more than this going on at the Sinus Center or ongoing. And Dr. Wang already mentioned the possible role of vitamin C in facilitating the chloride ion transport. And also, we're looking at long-term clinical outcomes of sinus surgery in cystic fibrosis and other medical conditions, whether a sinus surgery actually improves the patient's symptoms, their quality of life. Looking at some innovative nebulizer therapies and the role of vitamin A in improving the mucosal healing after sinus surgery. Lastly, so here is our team at the Stanford Sinus Center. We have Dr. Peter Wang, our director of the Sinus Center, and also Dr. J.K.R. Nayak, who joined us about a year ago. Is a PhD degree as well, focusing in research, but also see patient and do surgery. We have Dr. Zara Patel, who's the clinical instructor and the fellow receiving her training with Dr. Wang and Dr. Nayak, myself as a nurse practitioner. We also have a few research fellows, and they're holding MD degrees or PhD degrees, working with both Dr. Wang and Dr. Nayak, and some other doctors we work with, including the pulmonologist at the Stanford Center. And then lastly, our my patient in that picture, Amanda Padilla, is our medical assistant. So here I just list a couple of references I used for my talk. And this is our Building 801 Welch, on 801 Welch, otolaryngology clinic. Sinus Center is in this building as well. It's within walking distance from Lucille Packard Children's Hospital. And I'd like to thank you for coming. I also like to thank Dr. Wang as my mentor and helping me to develop the talk. Thank you.
Does anybody have an extra question that you would like to ask while we have this expertise in our midst?
Yes, sir.
For folks that travel, are there preventative coatings or things that can be done in addition to flying with a mask to prevent contamination in contained compartments like that?
It's a good question. I would think irrigation would be helpful, but I understand it's kind of cumbersome to, bring all your supplies and get the liquid. Do you have some input, Dr. Wang, specifically for travel?
Moisture is basically the key to good sinus health. So when you wear a mask, part of it is you think, well, I'm not going to breathe other people's air. which is part of it. But actually, the reason why the mask is so helpful is because you breathe back your own exhalations. And you don't lose the moisture, and that's why you get dehydrated on the plane, because there's what we call insensible oxygen. You lose all of that moisture to the super dry air. So when you put the mask on, you breathe back moist air, because you're breathing back mostly what you breathe out. And so that moisture keeps the surface mucous membrane functional. There's a layer there called the airway surface liquid. And in CF, it's disrupted just because we know that there's problems with the mucus. But for anybody, that layer is the protective layer for the mucosa. So other things you could do would be, for example, use some Vaseline in your nose, in the nostrils, and then moisturizing sprays and gels. You know, it's going to be, for example,